adult deformity is also a complex topic. It's probably less complicated than at least in the thinking about the treatment than idiopathic scoliosis. How is it defined? It's defined as a deformity of at least 10 degrees Cobb angle in the coronal plane. And what we see in our practice is mostly degenerative de novo scoliosis. So asymmetric degenerative changes at the disc or facet joint level. And sometimes it can be a progression of adolescent idiopathic scoliosis due to degeneration, but it's usually located at extremities of the main deformity. So it's lumbar or thoracolumbar region, and it's due to degenerative changes in a mobile segment. And this has been described very well in a paper published in 2005 by Max Eby. So degenerative scoliosis, there can be asymmetric loading, further enhanced by vertebral osteoporotic fractures, although there are some studies that show that there's no increased risk of progression in osteoporotic patients. It's also due to leg-length discrepancy, and there are often lumbar spinal stenosis symptoms. Here's an example of a de novo degenerative scoliosis at its very early stage, where you see an asymmetric disc degeneration at L4-5 level. And this is mostly due to genetic factors that affect the degeneration of the disc. And then you have rotatory dislocation that enters into play. For the adolescent idiopathic scoliosis, as I said, the progression is seen at the lumbar or thoracolumbar end zones of the adolescent curves, which is due to stress zones. The deformity is enhanced by disc and facet joint degeneration as well, and it's favorized by asymmetry due to scoliosis. The lumbar spinal stenosis is less frequent because the spinal column volume adapts during growth during the period of appearance of the scoliosis. And those patients can suffer from low back pain. This is an example of progression of adult-cell idiopathic scoliosis in adulthood. You see that there is an asymmetric facet degeneration at the L4-5 level again, and it can also actually manifest, as in this case, as a rotatory dislocation with appearance of degenerative spondylolisthesis. And this, of course, is related with lumbar spinal stenosis, as you know. Here's an image of this same patient. You see the asymmetry with an opening of the facet joint on the right side, and it's closed on the left side. And you have this shift in the coronal plane that shows the rotation on the MRI. This is a case of progression of adolescent idiopathic scoliosis in the adulthood. This patient has been operated on, and you see actually that there is a stress at the junctional zones, and a progressive shift of the coronal balance with an impingement at the concavity side. This is the initiation of the degeneration, and you see that this is always associated to some loss of lordosis. So adolescent scoliosis produces rather lordosis, but in the adulthood in degenerative problems, we see more frequently kyphoscoliotic deformities. What about the classifications? There are a lot of them. I'm not going to go through them. I'm just going to describe one which I think is useful. But you have Simmons, Schwab, SRS, Schwab, Lenke. I have a hard time understanding and finding all the cases, putting my cases into the classification. But this is the Schwab classification, which initially was only based on coronal plane X-rays, but then they added the sagittal modifiers, the PI minus LL, so the lumbar lordosis pelvic incidence mismatch, for instance. The problems are with these classifications that adult scoliosis evolution seems unpredictable in terms of deformity and symptoms because there's no growth like in childhood. And the degeneration of the disc is genetically driven, so it's really difficult to anticipate where the problem will be and how it will evolve. The symptoms are variable. It can be neurologic or back pain, and there are currently no clear guidelines, in my opinion, for treatment Do we have to do limited or extensive surgery? It's quite difficult. It's very important to look at the risk factors for progression in adulthood, and this is an interesting study that's been published in 2007, where they looked at 51 adult patients with idiopathic scoliosis, mostly were females, non-operated, with an average follow-up of 27 years. The first X-ray was done at an average age of 37 years, and the second one at 64. And they saw that there is a slope of progression that is steeper for the lumbar curve and the lumbar component of thoracolumbar curves. They identified two types. The type A, which is idiopathic scoliosis, mostly SRS double curves that continue to progress, so there's no time gap in the adulthood after bone maturity. And type B, which is a degenerative scoliosis, lumbar or thoracolumbar again, in idiopathic scoliosis with degenerative progression after a few years of a gap. And you can see that the risk of progression they identified are female sex, the menopause, where you see an acceleration of the curve progression. They defined it as type B, M for menopause. And if you have a Cobb angle of 30 degrees or more at the end of growth, you have a risk of progression, which is, especially if you have a single lumbar curve, of 1.64 degrees per year, with a range of 0.77 to 3.82. And they also saw a difference between type A and type B, where actually the initiation of the curve is a rotatory dislocation in type B, and the progression is much more faster than in type A. This is another interesting study by Kobayashi in 2006. They looked at 60 non-scoliotic adults, so they followed up patients of over 50 years old with a mean follow-up of 12 years, 10 to 15 years. And they saw that there was a higher incidence of progressive de novo degenerative scoliosis if there was a over 20% unilateral disc height decrease and more than 5 millimeter longer unilateral osteophyte. So the scoliosis, as I said before, is always associated in degenerative cases with kyphotic deformity. So the recognized identified risk factor today for progression in idiopathic scoliosis in adults is if you have a thoracolumbar or a lumbar curve over 30 degrees with apical rotation of more than 33% and a lateral isthesis of more than 6 millimeters. And for de novo degenerative scoliosis, so no previous idiopathic scoliosis, age and BMI are independent predictors. What does it mean? It means that scoliosis, degenerative scoliosis, is more common in older and lower BMI patients. Menopause is a phase of deterioration, and the rotatory dislocation is really the initial element of progression that is important to look at. So importance of follow-up have been, so the importance of the type of follow-up have been defined. If available, you need to look at all the previous X-ray that the patient has, and then do a systematic X-ray follow-up with full spine EOS at best. Every 5 years, if you have a young adult with a curve less than 40 degrees, every 3 years for curves more than 40 degrees, and every 2 years after 50 years, because especially in females because of menopause deterioration. Here you see a patient at 57 with degenerative scoliosis, and you can see the progression in 10 years, which is absolutely huge, and sometimes it's really difficult to differentiate from idiopathic scoliosis in the adolescent. Here you have a case with low-risk evolution, single thoracic idiopathic scoliosis young male, which is balanced in the coronal and sagittal plane. The risk of thoracic curve progression is low because you have 25 degrees or less deformity. There is a risk of lumbar curve progression because of this degeneration, so it's really difficult to predict what's going to happen here. But in this case, what is recommended is a full spine every 5 years or more. Here you have a different case, 50-year-old male, which has kyphoscoliotic deformity, 30 degrees thoracolumbar curve, and what you can see on the MRI is already some muscular degeneration. At 50 years old, this is very uncommon, with some asymmetry also in the psoas muscles. So the risk of progression exists here, and it was confirmed 3 years later with a progression of the kyphoscoliotic deformity. which also produced symptoms of mainly back pain in this patient. And you see that there's compensating mechanisms that have been put in place by the patient, for instance, the retroversion. This is a case of a 45-year-old female with two different curves, T1, T5 curve of 50 degrees. It's not a congenital deformity, as Claudio said it before. Here you have really high pressure in the concavity, and there's a contour curve in the cervical spine which produces symptoms in this patient of neck pain. But there is also this lumbar curve, which is 35 degrees. She is 45 years old, so there is a risk of progression at L4-5, a non-apical level, and then a progression towards the apex. So this patient needs more close follow-up. Clinical problems we see in adult deformity are low back pain in 40 to 90% of the patient. It can be in the curve or in adjacent areas. Mainly sagittal balance is implicated, as I'll show you. You can have lumbar spinal stenosis with neurogenic claudication, radicular pain, and it's due to rotatory dislocation in also most of the cases. Pseudoradicular pain can also be due to sagittal imbalance. It's a compensation sign of retroversion of the pelvis with pain in the gluteal muscles. Degenerative features that we see in adult scoliosis are disc degeneration, which can be in the curve or adjacent. You have three-dimensional hypermobility, instability. You have facet joint degeneration, which can be hypermobile, but they can also be very stiff because of osteophytes. You can have neurologic aggression or injury, which can be dynamic or static, and at any location, central, recessal, foraminal, extraforaminal. Rotatory dislocation is really the main feature of degenerative scoliosis, and it's very important to understand how the mechanics of this pathology. You can have a compression which can be central, subarticular, lateral, and one same root can be involved at different levels. You can have compression or traction of the root. Rotatory dislocation is classified according to the convex side. It can be open, closed, or parallel. If you look at the convexity here, so you can have an open dislocation or a closed dislocation, or if the end plates are parallel, a parallel dislocation. It's important to understand because you can have, as I said, for example, on the concavity side, you can have a compression of the nerve root on this side, but if you go down to the level below where there is this closed dislocation, on the other side you can have a traction of the nerve root because it's plunging down into the contour curve. Balance issues are also an important topic in degenerative deformities. It's, as I said, a combination of coronal scoliosis and sagittal kyphosis deformities. In the coronal plane, you have to look at the C7 sacrum offset. You also have to pay attention to the oblique start of the curve at the lumbar sacral junction, which is in adults usually stiff, and the loss of lordosis in the sagittal plane. Sagittal imbalance has shown, there are several other papers that show that it is correlated to function and pain. If you have over 4 centimeter offset in the coronal plane, you have a risk of having a very bad ODI of over 35%, so a really bad function which increases with the sagittal imbalance. However, if you have a high thoracic hyperkyphosis, it's much better tolerated than a loss of lumbar lordosis, which is shown in this graph of the study by Glassman. High thoracic kyphosis, the mean ODI is quite low, and it increases if you go to the lumbar spine and you have a deformity in the lumbar spine. Factors that influence balance in the elderly are pelvic parameters. You probably know them. The pelvic incidence equals pelvic tilt and sacral slope. Degenerative issues, so you have degenerative disc height loss, which, as I said, is genetically driven before. You can have instability or stiffness, and you have neuromuscular control issues. You can have idiopathic muscle degeneration, like in the case I showed you before. And sometimes you are dealing also with patients who have Parkinson's disease or Parkinson's-like disease, bent spine syndrome, the BSS, or camptocormia, which is a degenerative disease of the musculature. Scoliosis in the adult modifies the sagittal profile. You can actually produce kyphosis by the rotation of the scoliosis in these patients because of the degeneration. And you put in place, the patients put in place compensation mechanisms if they have strong enough muscles. So if you have a thoracic kyphosis, they can compensate with a long lumbar lordosis. If the deformity is at the thoracolumbar junction, they have short lumbar lordosis or thoracic lordosis, again, if they have strong muscles. And if you have lumbar kyphosis, again, thoracic lordosis, if they have strong muscles, but which is not always the case. For example, here you have a patient with thoracic compensation due to a strong musculature. And on the right side, you have a patient with very weak muscles or stiff spine, only bending x-rays, and your clinical examination will show you that. So this patient has a very important kyphotic deformity. Evaluation principles are, as I said, neurologic examination. You do have to ask for radiologic exams and analyze not only the coronal but the sagittal plane in these patients. MRI and CT, of course, for neural elements and also the quality of the musculature. And clinically, it's really very important, like in this case, to analyze your patient's posture and compensation mechanisms. For example, this patient here has kyphotic deformity after laminectomy, isolated laminectomy. But as you can see, she has very strong musculature in the thoracic spine, and she can compensate. But sometimes you have retroversion of the pelvis, which is a compensating phenomenon as well. And this can be mistaken for sciatica. It's a pseudo-radicular pain because you have a buttock pain, which can go down the lateral side of the thigh. You can have tight hamstrings, which can be mistaken for sciatica, or quadriceps fatigue mistaken for cruralgia, because these patients are often in permanent knee flexion for walking. What are the treatment modalities? You have obviously non-surgical physiotherapy. The brace, in adults, the brace is antalgic. There's absolutely no long-term corrective effect. You can use non-steroidal anti-inflammatories, injections. And then you have the surgical treatment, which usually is recommended in patients in good general health because it's a surgery with a high complication rate. Just one article that I found, there are other ones in the literature that shows that actually non-operative management in adult scoliosis has a very low success rate. So the surgical treatment strategies are important to discuss because we need to define what are the symptoms that we need to treat. Is it a focal problem or a more global problem, especially due to the coronal and sagittal imbalance, and what are the complications that we can expect? So the radiologic X-ray is important to analyze the global balance of your patients, and you also need to do sometimes bending X-rays to see what is the flexibility of the deformity, especially at the level of the lumbosacral junction. This is an example of a 71-year-old female with low back pain, radicular pain. She has a coronal offset of 4 centimeters, sagittal offset of 17 centimeters. You need to define before you operate what is the stiffness, what type of surgery you need to do. Do you do a PSO? Do you do pedicle subtraction osteotomy or less aggressive osteotomies? Should it be symmetric, asymmetric, and what is the extent of the fusion? These are the problems we have to deal with in these patients. So the bending is a helpful surgical strategy. Here you have the right side bending, the left side bending, and you can see that the lumbosacral junction is completely stiff, and there is some mobility, abnormal mobility around the apex of the deformity, and the thoracic spine is quite stiff. So the surgical treatment can then be decided. In this case, the same patient had a high pelvic incidence which needed a great amount of correction of the lordosis because of severe coronal and sagittal imbalance. The thoracic spine was stiff, and the patient had weak bone and weak muscles shown by the MRI. So you need to do an extensive fusion in this patient, and she had a pedicle subtraction at the level of L4 with extension with these amounts of, with these long fusions, you need to go to the sacrum. What about the oblique start of the lumbosacral junction? This is also an important topic, because if you have an oblique start with the imbalance that goes towards the convexity, like in this side, This means that you need to do an osteotomy around or close to the lumbar sacral junction to bring the patient back into coronal and sagittal balance. If, on the other hand, you have an oblique start with the imbalance that goes towards the concavity side, this is a completely different approach. In this case, it is recommended to perform an osteotomy at the apex of the main curve to bring back the patient into balance. So there is one classification which can be used in daily practice, which was published by Berjano and Lamartina in 2014. It's based on an analysis of apex and end zones. I think it was quite interesting to present you because it's quite simple. Here you have the type 1, which is a non-apical segmental disease. Like in this case, you have a degeneration, asymmetric degeneration of L5S1, which produces the progression at the non-apical level of the scoliosis. There's no sagittal imbalance, no mild compensated sign. This is a local treatment. It can be treated as low back pain. This patient had a lumbar sciatica and she had a single level fusion. This is another example of type 1, but in this case, as I said, there's only also a progression due to the appearance of degenerative spondylolisthesis, which was the case here. In a non-apical level, the deformity is above, and the surgical treatment could actually rebalance the patient. You see here the preoperative coronal balance, and the sagittal balance is also restored thanks to the correction of the segmental lordosis of L4, F5. Type 2 is a limited apical segment disease. Like in this case, there's no gross coronal sagittal imbalance, but there's a loss of lordosis of 10 to 20 degrees. Limited fusion is recommended, and this gives you the best option for the patient. Type 3 is an extensive apical and non-apical segmental degeneration and deformity. It's balanced in the coronal end. It's mildly imbalanced or compensated imbalance in the sagittal plane, but you need to do an extensive fusion to allow the correction of the deformity and avoid complications with the progression of the deformity. Type 4A is a deformity with very important kyphotic deformity in the sagittal plane, where you need to do a correction of over 25 degrees. So in this case, you need aggressive treatment. It's not imbalanced in the coronal plane, but you need to perform extensive fusion with 360 degrees fusions, so anterior and posterior. This is a case of type 4A, where you have deformity due to camptocormia, so she did not have coronal imbalance. The completely weak bones, and it was necessary to fuse the spine from top to bottom because she absolutely had no muscles that were working, and this patient was completely imbalanced looking at the ground in front of her. This is a type 4B with the severe sagittal imbalance, this time in the coronal and the sagittal plane. Here also you need aggressive surgical treatment. The complications rates get higher, obviously, because we're dealing with older patients, and a more aggressive surgery to correct the global imbalance. And you can have progression, for example, in this case from type 4A, which is balanced in the coronal plane, to type 4B, with an imbalance in the coronal plane and increased imbalance in the sagittal plane. So in these cases, you again need to analyze what is the compensation abilities of these patients. She has very weak muscles in the lumbar spine, but surprisingly, she has very strong muscles in the thoracic spine, because she has lordosis in the thoracic spine, and this is probably due to a previous decompression, surgical decompression. So in this case, we performed a limited fusion because she is able to compensate at the level of the thoracic spine. So we did an osteotomy at L4 to correct the deformity in the lumbar area and restore the lordosis, and a fusion which was stopped at the thoracolumbar junction. What are the surgical techniques that you can use to do that? There are plenty of them. I'm not here to describe and give the pros and the cons for one or the other. But one thing is sure, is that posterior approach is mandatory if you have to correct severe imbalance more than 25 degrees, because it's not enough to just put the cage in the front. You need to make some compression in the back. So it can be open, it can be minimally invasive surgery. There are papers showing that it's useful in milder deformities in adults. It can be PLIF, 360, anterior, posterior, whatever you want, transpsoas. Osteotomies also can be used, chevron interpedicular, or also called SPO, PSO, etc. And if you want to have some information about this and train yourself, we do a cadaver lab each year. This year it's on the 5th and 6th of October 2018. Dilemmas and complications of surgery. Where do we stop the instrumentation? This is a huge dilemma because we have complications like proximal junctional kyphosis. Do we need to do limited or extensive surgery? And the surgical complications are quite high in this population because of the age, for instance. And there are several papers that were published regarding this. These are 3 that I'm showing you here. But if you make a summary of what's available in the literature, it's very variable, but we can summarize the early infection rates, which are 4 to 16%, so really quite high. A radicular complication varies between 2.9 to 7.5% reported in the literature. Cord injury is not uncommon. It's up to 15% if you have junctional failure or proximal junctional kyphosis. Pseudoarthrosis is quite high also, probably because also at that time we didn't include the treatment of the disc itself, so more and more we're doing fusions, interbody fusions, which probably will decrease this rate of pseudoarthrosis, especially at the lumbosacral junction. And age also is very important, because older than 60 years old, you increase the complications rate, be it medical or surgical mechanical complications. What about the limits of the fusion? In the proximal area, you need to stop at the stable, neutral, unhorizontal vertebra in both planes, which this is the theory. It's not easy to identify. Avoid ending at apex of kyphosis or predicted apex of kyphosis. You need to do a simulation to appreciate that. You need to appreciate muscular compensation ability. You have to look at the MRI to see the quality of the musculature. And beware if you want to stop at the thoracolumbar junction because of the lever arm. And you have to include, this is recommended, lumbar sacral junction if you do long fusion, so longer than the lumbar spine. If you do huge corrections of coronal and sagittal imbalance, and if you have an oblique start at the lumbar sacral junction. This also depends on the age of the patient. Obviously, if you have younger patients, you want to try to avoid to include the lumbosacral junction. But this is an older patient mistake that I made. Older patient, 80 years old, where I thought the fixation at the sacrum was enough. And actually, if you see the postoperative x-ray, he had a nice rebalancing of the spine. But a few days after the surgery, he complained about increased pain, and we did a CT scan. The screw at S1 were already loosening, so we had to go back and increase the fixation at the level of the lumbosacral junction. How to avoid PGK or PGF very quickly. Several risk factors have been described: the muscle quality, the bone quality, the BMI, comorbidities. It depends also on the amount of correction. If you have a huge amount of corrections, you increase the risk of PGF or PGK. And it's very important to try to respect the harmony of the curves, especially respect the lordosis at the L4-S1 level. And we did a small study where we also looked at the identification of the lever arm, because it's really a matter of lever arm bending moments. So if you have a weight that is away from the spine, you will increase the stress on the vertebra. This is the principle. So if you have a case like this, where you have a huge deformity in the coronal and sagittal plane, you know that you will have a great amount of correction to perform, and you have to be careful about the distribution of the lever arms around along the spine from top to bottom. So we did a small software where we used data available from the literature about body volumes and the percentage of weight. And we made a little calculation where we actually could use then this software to try to define where the maximum lever arm momentum bending is. And it was used, for example, in this patient. This is only a simulation, so we need to verify this with the clinical study. And we found that, for example, in this case, the T12 vertebra was the site of the maximum lever arm bending moment. So we used it in a few cases where that we looked at retrospectively. For example, this case here, we found that the retrospectively that the maximum lever arm was at T12, and after surgery, we found so retrospectively that we were wrong to stop at this level because we actually ended up with a junctional kyphosis, and there was also probably a lack of correction of the lumbar lordosis in the lower segments. This is another case with a patient who also had stronger musculature. We identified the maximum lever arm, which is at T8, and retrospectively we looked at this case and we found that we were correct to ending our construct at the L1 level. The patient was operated for a progression of the deformity and back pain in the proximal lumbar levels. So this one did not end up with a proximal junctional kyphosis. If you're interested to look into this a little bit more into details, we just published these two papers regarding this in the European Spine Journal. So just to finish, current recommendations for severe adult deformities. You need to do or consider extensive surgery or no surgery if there is a severe imbalance, because it's better to do one big surgery dealing with the whole problem than several others previous surgeries that actually give you more complications afterwards. The current rate of major complication is quite high. It's 30 to 40%, with a 40 to 50% patients needing reoperation within 6 years, which is really huge. But the clinical improvement is maintained. If you do a PSO, there's a high risk of mechanical complications. So the current recommendation is to use 4 rods with a solid iliac fixation, and to treat all the discs around the PSO, including L5S1, to avoid pseudarthrosis rates, for instance. In conclusion, adult deformity is a 3-dimensional deformity, and the problem is that we still have 2-dimensional deformities, so there's still some room for improvement and for simulation tools, especially intraoperatively simulating tools that allows us to see what we're doing, what correction we're doing. It doesn't concern only bone, it's also neurologic control and about quality of muscles. The coronal and sagittal balance is important to analyze to decide which will be the upper instrumented vertebra or the lower instrumented vertebra. And it's a high-risk surgery, so we really need to discuss with the patients multiple surgery risk. So we have to tell them that it's really not a surgery of one shot, it might be several shots. Thank you for your attention.